Hi everybody, I'm Milo, and my final project presentation topic is on tuberculosis. Alright, so first I'm going to give a little bit of an introduction and some history about the disease. It's caused by the Mycobacterium tuberculosis bacteria, and it mainly affects the lungs. About 90% of cases that are active just affect the lungs area. Symptoms of the lung-based infections include coughing up blood, fever, weight loss, like chest pain, just problems with the lungs. Tuberculosis has been infecting humans since antiquity. We found evidence of spinal tuberculosis in mummies in Egypt and also in bones of bison in North America that were dated from 17,000 years ago. Another fun fact about tuberculosis, it was discovered, or the bacteria that causes it was discovered in 1882 by Robert Koch, and he won the Nobel Prize in Medicine in 1905 for that. Now I'm going to give some statistics about tuberculosis and explain why it's important. I mean, this one's pretty obvious. Worldwide, it kills 1.5 million people every year. And they estimate that about 1.8 billion people worldwide are infected with a latent variant of the bacteria. Like I said, that's 90% of people who have this asymptomatic infection. And if you are asymptomatic, you have a 10% lifetime chance of having the tuberculosis activate and giving you those like coughing, blood, and fever and weight loss symptoms. There are some people that are at much higher risk, such as those with HIV. If you have HIV, then you have a 10% chance every year of the asymptomatic tuberculosis reactivating, not just lifetime. In terms of treatment, you use antibiotics, but the problem is that the bacteria is pretty resilient to antibiotics, and it requires a treatment that takes like 6 to 9 months, and you need to use multiple antibiotics, and they're constantly evolving resistances to new antibiotics. And it's really important that we treat these active tuberculosis cases because if left untreated, 50% mortality rate. That's really serious. So here's a couple maps explaining the distribution of tuberculosis across the world. In terms of incidence, it's mainly an issue in South Asia, Southeast Asia, East Asia, and Sub-Saharan Africa. We see most of our infections, in terms of per capita, the countries with the highest numbers are South Africa, Lesotho, Mozambique, the Philippines, and North Korea. This is due to a number of reasons. There's less treatment there, less antibiotics, and just less overall testing as well. And over to the right here, we can see a map of the deaths by region. If you look at it, a good majority of the deaths occur in South Asia, so that's like Bangladesh, India, Pakistan, as well as Sub-Saharan Africa. And these regions tend to have the least medical infrastructure for treating it. The high prevalence of HIV in Sub-Saharan Africa is another big reason for tuberculosis. The two go hand in hand. If you notice, it looks like Southeast Asia and East Asia also have a good number of deaths, but outside of those regions, tuberculosis doesn't really kill that many people. But it's still a really important thing, and this virus has been, I think I read somewhere that it accounted for up to 25% of deaths in Victorian England. All right, so this is my GIS-based case study. I picked out something a little different and pretty interesting in this one. It's called Predictors of Latent Tuberculosis Treatment Initiation and Completion at a U.S. Public Health Clinic, a prospective cohort study. It was published in Biomed Central Public Health Journal, and these here are the authors. I'm not going to read them out because I can't pronounce half of those names. But it seems to be a really diverse crew that is creating this paper. So the conceptual design, this part's pretty interesting because it's not specifically looking at the factors that influence the risk of the disease, but it's looking at factors that contribute to a patient's willingness to initiate and complete treatment of latent tuberculosis. So one thing that I should explain, latent tuberculosis is the part that's infecting 1.8 billion people worldwide. It's got like a 10% chance of becoming activated and causing those like coughing up blood symptoms. But it's still really important that we treat this, because even if somebody has latent tuberculosis, they can still spread it to others. And if we want to like combat tuberculosis, it's really hard to combat because of that like 4 to 9 month treatment period. We need to treat people that aren't necessarily displaying symptoms. And that's like the main method of treatment and prevention in developed countries like the United States. So this is a pretty wide range study. It's looking at a lot of factors, such as the length of time, and there's a person staying at their current residence. That's a habitat vertex. Education level, population vertex. Access to primary care, that's habitat again. Whether the person fears medicine and they believe in medicine in general, those are both behavior. We're looking at some population factors like race, gender, age, nationality. Another habitat vertex is they look at poverty level in this study. In terms of behavior, they're also looking at like high-risk behaviors. And then they're also looking at other like high-risk conditions that would fall into the population vertex, like having HIV or diabetes, both of which increase the mortality of tuberculosis. So the methodology design, it's a prospective cohort study. It follows a group of individuals over time. The data collection, every adult who qualified for tuberculosis treatment that entered the specific clinic in North Carolina between 2008 and 2009, and it's 496 people. Everybody in the study met CDC guidelines for the treatment. They all had either a positive blood test or a positive skin test. Most of the medical data was collected by a check, and also a questionnaire about the social factors. The results are finding out whether a person initiated or chose not to initiate, and if they did, it finds whether or not they completed the treatment. Okay, so about the GIS data collection and results. The spatial component of the study, they were looking at permanent residences that people filled out in the surveys, and they geocoded them. They got 391 addresses. And looking at the results here, the distance from the clinic was not a serious factor for initiating or completing therapy, but people living in low poverty neighborhoods were more likely to complete the treatment. This is the results of the survey that they filled out. For the beliefs in socioeconomic factors. Anything smaller than 0.1 p-value is considered significant in the study. In terms of initiating the treatment, some factors that were significant were living in the same house, believing that you can get sick from tuberculosis, and going to regular primary care. There's not much significance between this survey and a person's likelihood to complete the treatment, though. This is the results of the medical check. And this one found the effect of demographics and risk factors and behaviors. People that were at low risk of like getting the deadly part of tuberculosis were found to be less likely to initiate treatment. People that were formerly in jail were more likely to initiate and complete the treatment. People with close contact to a tuberculosis case were far more likely to initiate treatment. And people who came into the clinic because of mandatory employment screening were much less likely to initiate treatment. So some conclusions. The main issue that this study found is the patient's willingness to initiate treatment, and only 26% of people actually chose to initiate the treatment. But of those that did, 55% completed. And they noted this is lower than some other studies, but that's mainly due to differences in the population sample. Like this is rural North Carolina we're talking about. They also found that people at high risk were slightly more likely to initiate the treatment, but they had the same likelihood of completing the treatment, and it wasn't a very significant difference. And the distance to the clinic wasn't really a factor, but people in low poverty areas were more likely to complete the treatment. That's important. And here's some limitations of the study. The results are slightly less generalizable because there's only one clinic involved in the study. Generally, you'd want, a couple of different population samples to eliminate some of that population bias. A large proportion of the population, I think it was something around 300 out of the 496, were there because of mandatory employment screening. And people who did that were notably far less likely to initiate the treatment. There are small numbers of the high-risk groups just because of the small sample size. And additionally, there weren't as many people that completed the treatment as there would want to be for good statistics. And so that kind of limits the power of the multivariable analysis. And here's my references.